everybody. Thanks for joining this this web meeting. Julie asked me to talk about the PDA. This is one of my favorite topics, and I'm going to try and take you to a journey of how we got where we are now and some new information of how we can move forward. So let me see. Yes, if you're my age, but probably also younger, we've all been sort of raised with the traditional concepts of the PDA. It's a fetal shunt. It's supposed to close after birth, and if it doesn't close, we need to close it. We need to do something for that. And that's because of the PDA pathophysiology. And I think we learned a little bit over time more about PDA pathophysiology, but it's one of increased left ventricular preload and reduced left ventricular afterload. It's a bit of a strange combination. With the increased preload, you get increased pulmonary blood flow, and you get an increased volume load of the left heart, the left atrium, and the left ventricle. With the decreased afterload, you get a reduced systemic vascular resistance and also reduced blood pressure, and that can certainly lead to reduced organ perfusion pressure, which is regulated in each organ individually. The PDA is a very frequent complication. All of us, if you're a neonatologist, have to deal with this, I think, at least once a day on your ward rounds. This is our data in 127 babies, 28 weeks and below, where in the first 10 days, 30 to 50% of the babies will have a PDA larger than 1.5 millimeters, and about 12 to 20% larger than 2 millimeters. And then if you look at the data, when I started my training, this was the
Sorry, Kurt, I moved you by mistake.
I'm unmuted now.
Yeah, sorry.
Yeah, okay, right. So in many studies, in univariate analysis, shown that the PDA is associated with very common neonatal morbidity. It's heart failure, hypotension, low blood flow, prolonged respiratory support, pulmonary hemorrhage, and the development of chronic lung disease, or BPD, and vascular abnormalities such as IVH and NEC, which will all have their individual impact on their developmental outcomes. So it seems very simple, but if you take that PDA out of the equation, then everything should get better. The treatments which were available to us have also evolved sort of over time. It started with surgical ligation already in the early 40s, and then we got pharmacological treatments in medicine 20 years later, followed by ibuprofen, and 20 years later, followed by paracetamol. And the newest things, which I will come back to a little bit later, is transcatheter closure, which sort of started from 2010. So surgical ligation was the only tool we had before endomedicine came out. And this is one of the key papers which sort of describes of how to deal with surgical ligations in preterm infants with a PDA. This is a group of pediatric cardiologists, major names in pediatric cardiology, Rudolph, Hyman, Kitterman, and they describe that we recommend cardiac catheterization and operative closure of a PDA in neonates where heart failure cannot be controlled medically. And medically at the time was diuretics and digoxin. If you look in that paper though, and this is the list of signs and symptoms they give, which they call heart failure. If you look at that list, this is something which we see actually in every preterm baby, particularly the younger ones, and particularly the ones with evolving chronic lung disease. So I would say these signs are actually not very typical of heart failure. But then in '76, they came out with endomedicine after some laboratory studies, and they found this breakthrough treatment in the patent ductus arteriosus. No longer was surgery needed as much anymore, so we can do pharmacological. And as good clinicians and researchers at the time, a couple of years later, this first large multi-center randomized controlled trial on PDA treatment was performed. And it was a very nice study. It was complex, but it was nicely designed. 405 babies, good size, 500 to 750 grams with a symptomatic PDA. who were then randomized to either receive indomethacin or placebo, and both arms would have a variable amounts of backup treatments, either surgery or indomethacin and then surgery. The results of this trial, however, was a little bit disappointing. PDA closure rate was increased with NSAIDS, but mortality, no difference. Anything respiratory, duration of mechanical ventilation, CPAP support, or development of BPD, no difference. And only some complications were associated with ligation, such as pneumothorax, severe ROP, and length of stay. And to be honest, I'm going to take a big jump forward, but what we've done over the last 30 years is actually repeating this trial and sort of expecting different results. But we didn't. We got the same results. Over 50 randomized controlled trials with almost 5,000 babies. And the primary outcome, ductal patency, was reduced. However, all the secondary outcomes, medium and long term, except reduced IVH with prophylactic indomethacin only, not ibuprofen. And there was one small study preventing pulmonary hemorrhage. So what is going on? Even prophylactic indomethacin, and I made this slide last year, where I sort of summarized recent observational trials and looked at the rates of severe IVH, grade 3 and 4. In the original TIP randomized controlled trial with prophylactic indomethacin, that rate was about 9%. But in trials later on with sort of comparable sizes, sometimes even bigger, those rates were never matched ever again in clinical practice, which is very disappointing. So PDA closure with indomethacin or ibuprofen, the NSAIDS, did not improve clinical outcomes. So you have to ask yourself some questions. What's going on there? Is this based on solid methodological data? And we'll go into that. And maybe also more importantly, is it possible that this treatment is actually causing harm? Let's go to the first one first. We do know that many PDA trials have methodological issues in their design. It's about the selection of eligible infants. There's a high rate of open label treatment in both arms. And I think we also came to realize that NSAID treatment is not effective enough in closing the PDA. So Inge Zonneberg, one of my fellows back in Amsterdam, did a systematic review where she looked at 67 randomized controlled trials to see at what point the babies would be randomized, so the trials would call that a hemodynamic significant duct. And we were quite shocked by the findings. She found a wide variety in what people called a hemodynamic significantly PDA in the trials. And some trials had no or minimal documentation of actual PDA physiology and PDA shunt size. Second to that, she also found that over half of all the trials included infants which were 30 weeks and above, or 1,500 grams and above. And if you look at this particular table, which looked at spontaneous closure rates at day 4 and day 7, in that particular group, it's 90 to 100%. So you could really argue that these kind of babies probably don't need a difficult discussion about should they give a medication with possible side effects or not. This is maybe the most difficult part of the methodological issues in PDA trials. What happened is that lots of babies in the placebo group were allowed to receive open label treatment. And this happened at an average of 52% in all the trials thus far, which reported on this particular outcome. Now it sounds trivial, but what it is, these trials are actually not placebo-controlled trials, and I'll try to explain that in the next few slides. So you get your trial participants, which were randomized to either receive NSAIDS or placebo. So it looks like a true placebo-controlled trials. And out of these groups, the PDA could remain closed or open. And of course, it was more closed in the NSAID group versus the placebo group. We do know that. But then in the open, babies who still remained a PDA open, they all still received NSAIDs. So basically what happens, these are not placebo-controlled trials. These are earlier versus later NSAID treatment trials with a cohort next to it, which is the control group, which closed all spontaneously. Now, if you look at that a bit more in more depth, it also says something about NSAID efficacy. So the median spontaneous closure rate, so the closure rate in the placebo-controlled arms in the trials was 40%. So this 40%, this rate is also expected for NSAIDs, for infants in the NSAID arm. So the true NSAID efficacy to close the PDA is much lower than currently quoted. It's usually quoted around 70%, sometimes 80%. But you can imagine that at least 40% of that 70 to 80% would have closed without NSAIDs anyway. So the actual true NSAID efficacy is probably below 50%. The second question is a bit more daring to answer, but let's go have a look at this. I got two arguments that I think that NSAIDs are causing harm. NSAIDs are potent, unselective vasoconstrictors, and we have lots of data which show that NSAID during their administration reduce renal, mesenteric, cerebral, and coronary blood flow. The second has to do with vascular remodeling of the ductus arteriosus and how that should work. The ductus arteriosus is a rather unusual vessel. As a fetus, it needs to stay open, and then when you're born, it needs to close, which is very different than, say, the aorta, which has to stay open all the time. So the ductus arteriosus has a genetically imprinted vascular remodeling program in it to prepare for closure closer to birth. It does this by changing its external elastic lamina, called elastogenesis, and then it gets some intima cushion formation where the walls would get smaller and smaller, and then you get some smooth muscle migration into that cushion to prepare for closure earlier after birth. Now, this Japanese group found out that the specific gene and receptor which is involved in this process is the PGE2 EP4 receptor. And that receptor actually has a dual role. As a fetus, it is designed to make sure that the ductus stays open. And that's actually the pathway we use with NSAIDs in the medicine and ibuprofen to make sure that the PDA closes faster. However, this same receptor is actually also responsible for all the remodeling changes in the ductus arteriosus, which are needed for final closure. So this was something very new to me, and I thought, like, this is odd. Let's go have a look at our own cohort and see how babies respond if you give them NSAIDs, because it's I think everybody's experience that the young babies don't respond as good to NSAIDs as compared to the older babies. And indeed, that's exactly what we found. This is again about 150 babies, and we looked at the probability of PDA closure with NSAID treatment. And we found that in the younger gestational age group, the blue bars, between 23 and 25 weeks, the probability of closure was much lower, even when you sort of adjusted for postnatal age, compared to the group of 26 to 28 weeks. We thought about this and we penned it the double hit theory. What if you have a period of vasoconstriction induced by NSAIDs and it didn't work? So you get delayed PDA closure on top of it. Could that be the reason why this particular group have poor neurological outcomes? We already know that persistent PDA, with or without treatment, babies have a poorer outcome than babies with a closed PDA. And this is just one example from Australian data, New South Wales data, I think it is, where they look at functional disability at 2 years of age in 1,473 preterm infants with a PDA who either received NSAIDS or received conservative treatment or no NSAIDS. And they found that the functional disability was much higher, only in the younger gestational infants who received NSAIDS versus not. Now, this is only circumstantial data. I would not say that this can be true, but this is something certainly we should consider. I think we can say, though, NSAID treatment to close the PDA is an inadequately tested but frequently prescribed treatment. There's a poor patient selections in the trials. There were very variable definitions of a hemodynamically significant PDA, and there is no real placebo-controlled trial available to tell us if this is effective or not. Further, I have shown you that NSAIDs have poor efficacy, especially in the very young gestational age infants, and that NSAIDs might be harmful, either by delaying the ductal closure or through other mechanisms. So I think this is where we ended up in the chicken and egg situation. Is it the PDA? Is it the treatment? What do we have to go from here? What can we do now? Well, let's look at the alternatives to NSAID treatment. And a couple of alternatives have come up recently and are better described than they used to be. We have some non-invasive treatments, which is paracetamol and supportive care or conservative treatment. And we have some more invasive treatments, which is surgical ligation, which has always been there, and transcatheter closure. This is the latest systematic review I could find on paracetamol trials, but I know there are at least two in the last, 2 or 3 in the last 2 years, which wouldn't have not been included in this particular systematic review. However, I do think they all show sort of similar results when compared to NSAIDs, either ibuprofen or indomethacin. It feels like most of the outcomes, including ductal closure, are very similar between paracetamol and NSAIDs. All the secondary outcomes and even possible complications are also the same. So this seems like a very viable alternative to NSAID use, at least. However, though, these trials, and particularly the first 7 or 8 which were included in this systematic review, have again the same methodological trial design issues. They included infants over 30 weeks of age, maybe in a chase to get a higher sample size. They would all allow open label treatment, and there's no comparison against just placebo. And the little saying on the side is a Dutch saying about a donkey who generally doesn't hurt himself twice against the same stone. But I feel with paracetamol, we're sort of chasing the same concepts, but not moving on with understanding if we actually need to treat the PDA. The second what came up is supportive care or conservative treatment. They're not the same. We would like to think that supportive care is treatment of pulmonary volume load and other consequences of PDA volume load. And generally 3 components, but there might be some more, which I'll get back to later. Optimizing the PEEP setting and your respiratory support, careful fluid management, and the addition of diuretics. In conservative treatment, in the initial sort of cohorts, was like it just meant no treatment. There's a significant reduction in NSAID use and PDA ligation. But I think nowadays those 2 words are used together and not always mean the same thing. So you have to look carefully in the trials what they mean with supportive care or conservative treatments. So if you apply conservative treatment or supportive care, which we would like to do, you need to do that till spontaneous closure occurs. So ask yourself the question, how long is that for? I think the best data about this one is probably this one from Semberova. I think it's a 2-center trial in Europe, which looked at almost 300 babies with a PDA, and most of them had actually conservative care. And in different color codes here on gestational age, you see the older gestational age, the purple ones all the way at the bottom. It took about 6 days for half of them to have a closed PDA. The 28 to 29 weeks, about 8 days, not much longer. The 26 to 27 week are about 13 days. But look at the babies less than 26 weeks, which is the red line. It took an average of 71 days till only half of them had a closed PDA. Well, this will have a significant impact on how you as a clinician have to deal with this volume overload. This is a study about supportive care. It was from Korea. They actually changed their policy rapidly from one particular mode to a second mode. There were almost 180 preterm babies of very young gestational age. And in their first epoch, they did an ultrasound at day 7. They give NSAIDS, another ultrasound. Second quarter of NSAIDS, another ultrasound. And if the PDA was still open, you got ligation, which you can see the cumulative incident rate of PDA in that particular group was very short. Most of them would have their PDA closed very early. The BPD rate in that epoch was 58%. And then they changed to supportive care. In that supportive care, they still got an echo on day 7, but nothing else. They did get some diuretics, postnatal steroids were discussed in this study, and supportive care with PEEP settings was discussed in this study. And maybe a little bit to everybody's surprise, but also to theirs, that BPD rate significantly reduced. So this is an important study which shows that a major change can have a major impact on particularly the outcomes which you think are associated with PDA. There's one but though, particularly on this particular trial, because they also reduced their ligation rates significantly. And this is what we know about ligation. Then wise from the US, does reason Canada or US, he does studies where he systematically reviews cases with surgical ligation. Now we know from surgical ligation they've hardly been tested in a randomized fashion. There might have been 3 or 4 trials which showed no difference in mortality. But when he compared a large group of baby and separated into the ones which were ligated, a median of 28 days, compared to the ones which got medications, particularly NSAIDs, he showed a reduction in death. However, that could be at the cost of an increased rate of moderate to severe neurodevelopmental impairment, chronic lung disease, and retinopathy. But then in this particular trial, and I recommend you of reading this, he did some further statistical analysis where he tried to balance the disease, illness, severity of these kids, and then did comparisons again, and where then these last three sort of components were significantly reduced as well. Still up to date, we still don't have a good trial which shows that surgical ligation, according to a randomization process, have shown benefits or not. And to be honest, I doubt that it will ever happen, because now we have transcatheter closures. This is a much less invasive technique than surgical ligation, and the experience about this technique is increasing all over the world. There's two FDA approved sort of devices, and the catheter goes into a vein, into your groin, up into the right ventricle, into the pulmonary artery, and then to the aorta, towards the aorta to the PDA where the occluder is placed. Then, as I said, the success rate of the procedure has significantly increased. The complication rate has significantly decreased. And this is probably the largest study I could find in the population we as neonatologists usually deal with, of sort of 1 to 2 kilograms of age. This is 102 babies, where, as you can see, the youngest were very small, but on average about 1,500 grams at the procedural weight. And the complication rate was actually really low. So these devices can press on vascular structures next to it, such as the left pulmonary artery or the aorta, and the catheter itself has to go through the tricuspid, and it can do some damage over there. The death as presented in this particular study were claimed not to be due to the procedure, but it could have been related to PDA complications. So with this list of treatments in mind, what is now the best treatment to close the PDA? I'm not talking about clinical outcomes, but what's actually the best treatment to close a PDA? And Mitra did a systematic review looking at this. So he looked at all the different sort of comparisons which are available in the literature, including indomethacin, ibuprofen, and acetaminophen, so paracetamol. All pharmacological closure techniques, either IV or oral. He found 60 trials, over 4,000 infants. And the one which came out best was actually high-dose oral ibuprofen, had the highest likelihood of PDA closure. He also made a comment that supportive care is not likely to increase mobility. Mortality. But as mentioned in a lot of these trials, babies in the placebo group did receive open label treatment. And I added to this that unfortunately transcatheter closure has not been tested in a randomized comparison, because you would wonder which one is actually even better. I guess a catheter is better. I'm not saying it's safer, but it might be better to close a PDA. So the questions of which is better to close a PDA is important, but I think we should still come back looking at the history of what we've been doing about PDA understanding and PDA trials to should we treat the PDA, and particularly who will be best benefit from treating the PDA. And already there's been some calls out for this particular trial design. Bennett did one in 2010. He looked for a definite trial comparing current standard management with novel strategies, not primarily intended to achieve ductal closure. He called it supportive care back then. And Nick Evans from Australia is a bit later, but he said, no, no, he wants the same. He wants to solve this conundrum. And the only way to do that, compare early targeted ultrasound treatment with a controlled group in which the PDA is truly never treated. And I guess people are a bit scared still of doing these kind of trials and are hesitant that this is actually a question we need to solve first before we can go further with what is the safest kind of treatment, if that is the best. So there's two trials I'd like to discuss with you which had the intention to go into this question, but they're both pilot trials, but they come up with a lot of very important information of how we can go from there. The first is the PDA Tolerate study. It's a pilot trial by Kleiman and his group, which want to look at earlier versus slightly later, but particularly NSAID or paracetamol versus placebo in a group of babies which were of young gestational age, a little bit older, but that's the American way, 6 to 14 days of age, had a PDA with volume load on ultrasound, and had greater than minimal respiratory support, which is further defined into the paper. As said, they compared NSAID or paracetamol, because there was a European centers in there as well, I remember, versus placebo. Open label treatment was allowed, but it was sort of discouraged in the trial protocol. Now, let's see what happened. Their primary outcome was PDA ligation or outpatient PDA follow-up. There was no difference. And all the secondary outcomes, and I mentioned a few here, but there are way more into the paper, no difference. But I think what was slightly disappointing, what he was not hoping for, is the high rates of open label rescue treatment. 48% in the placebo group received open label treatment and 18% in the NSAID arm. What is important in the detail of this study is they systematically reviewed the eligibility infants and how they got into the study. Because there are infants enrolled in the study, which you can see all the way on the right. There was only 24% of eligible infants, which is rather low. And he found that half of it was due to the clinician, which most of them wanted to treat versus not wanting to treat. But the other half was actually the parents, which said, no, I don't want to join this trial. And I'll go a little bit more deeper into that in our trial, because that is a very important aspect, you know, how to explain a trial like this to parents. Because we did our trial fairly similar to Kleiman's study. And our aim was also to find out in a pilot trial, how can we design the perfect trial? We called it the ultimate PDA trial. Can we design it? Can we sell it? Can we do it? So we did this pilot trial. The aim of the pilot trial was to investigate certain areas of uncertainty about what a future PDA trial should look like. We started off with a big survey in ANZN and asking everybody, you know, do you think it should be early treatment, late treatment, what medications, what doses? We asked them a lot of questions what the clinicians in our region would think about what a future PDA trial would look like. And when it finally came to sort of starting the trial, we looked at three particular items: the willingness of clinicians to recruit patients, but also the willingness of parents to consent to this study, and also the clinicians' aptitude towards avoiding open label treatments. Can we do that? Apparently in Kleiman's study that was not possible. This is our flow diagram of the trial. It's actually really classic. We started with the recruitment phase of looking at eligibility criteria, and then fairly, a little bit broader than the tolerate study. We looked at young gestational age. We did early treatment, which is much more common in Europe and Australia. I'm not quite sure about Asia. And we looked at broad PDA criteria. We do not think that a PDA over 1.5 millimeters should be the only criteria to treat a PDA. But we like to do a big trial so you can do subgroup analysis afterwards. Which one of the added ultrasound or clinical criteria will actually best select babies who can benefit from treatment? The intervention phase was up to 10 days of age, was a very true, basic, randomized controlled trial. You either got treatment or you got placebo. I think the most difficult part, and we go a bit more detail into that later, is the post-intervention phase. We did some ultrasounds to follow up what the PDA would do, but at this phase, the clinicians who or the participants were not allowed to be offered open labor and NSAID treatments. We did provide supportive care, and we should triage them for possible ligation. And as the outcomes, we choose death and BPD because we think those two outcomes are most related to PDA pathophysiology. Our supportive management was actually rather broad, but also just descriptive. Optimize the caloric intake by providing early enteral feeding and grade if tolerated, because some clinicians would tend to not give enteral feeding if they give NSAIDs. The DEFI trial luckily sort of took that fear away from us. So provide calories. Consider postnatal steroids for infants with evolving BPD and significant respiratory support for more than 10 to 14 days, and maintain PEEP until PDA closure, which could be long. On the fluid management, we discussed and reviewed the available evidence. You shouldn't go too high initially, that's one thing, but it wasn't in the trial protocol. But we did say that you should reduce the standard fluid intake by a maximum of 10 to 20%, because there is some evidence that if you reduce it even more, that might be not beneficial to perfusion pressure. And then we would prescribe a brief period of loop diuretics for clinical heart failure, particularly if there was ultrasound evidence of diastolic dysfunction. And I will detail that a little bit later as well. So we did 2.5 years of recruitment. And remember, this is a pilot trial. The idea was not to get a large sample, but to get enough per month. So a true trial in the whole of Australasia would work. 240 preterm infants, lots of them approached. 54% of the parents consented. Now that sounds good. It's more than, I think, in the trial. It's less than the trial of climate. And it's actually also less than we were used to in other hemodynamic studies we have performed over the last years. The condition not offering parents to join the study only happened on 4 occasions. The parents not wanting to join the study, so that's the 46% of the cases. And open label treatment was only given on 2 occasions. So it was pretty good. 71 infants were randomized, which was 63% of eligible. That's significantly higher than the PDA tolerate study, even though we had shorter time to get these patients into the trial and much less centers to do the study. They were around 26 weeks, and the time when they were randomized was around 53 hours. Not as early for instance, Nick Evans, and would want, but there were infants in there which were early or randomized than others. PDA closure, I think, as expected, was much higher in the NSAIDS group, 74% compared to 31% in the placebo group. However, the primary outcome of the main trial, which is chronic liver disease or death, no difference, 60% versus 67%. All secondary clinical outcomes, no difference, which include early complications like IVH and pulmonary hemorrhage, respiratory support status, abdominal components, retinopathy, length of stay, and none of the infants required PDA ligation. And I already alluded a little bit to this. I think the most difficult part was to get parents on board, was to explain this trial. A PDA trial has many different questions to answer, and only the intervention phase was very easy to explain. But what happened after the intervention phase was actually very difficult to explain. And I think the second thing, which was a sort of a barrier to consent, that is much easier to explain the trial with a new promising treatment, whatever it is, compared to challenging a treatment that has been common practice for now over 5 decades. We did learn from patient selection though in this trial, and we reached out to what the adults would do with volume overload. And they look at diastolic function of the heart and diastolic heart failure in these particular situations, where they use ultrasound parameters to categorize these patients. LA volume index, EA ratio, tissue Doppler parameters such as the E prime or the E prime ratio, and a TI jet velocity. And then we did a study within this study to look at the 2 standard deviations for stable preterm infants, and you could find sort of cut values for this. And then you could diagnose or define diastolic dysfunction, which is either clinical disease and 2 out of the 5 parameters abnormal, or more than 3 out of the 5, more and equal than 3 out of the 5 parameters abnormal. And this showed a very interesting concept. We found out that 18% of preterm infants have diastolic dysfunction on the ultrasound. And the prevalence, the cumulative risk of diastolic dysfunction in infants with a PDA will just increase with each week they're exposed to PDA. And particularly in my center, we use this now as a selection of patients for supportive care treatments, particularly diuretics, later on in the after the intervention phase of a PDA. As you can see from this graph as well, that this parameter or selection is not very helpful in the first 10 days of life. So I come to my concluding slide so we can have some discussion about the many questions, because I haven't solved anything, and I think we as a group haven't solved much as well. We still don't know if we should use NSAIDS or paracetamol for that matter to treat the PDA. Who to select for treatment. Is still uncertain. I think we're getting more and more evidence, including our own pilot trial, that supportive care is feasible and possible without changing clinical outcomes. I think we need at least 1,000 very preterm infants with a moderate to large PDA to solve the many PDA questions, either early on in the midsection or later on when it doesn't close with any kind of intervention you have applied of how to deal with this particular patients. All the supportive care treatments, including diuretics, PEEP settings, fluid management, have not been tested in a true large randomized control fashion. I think what we also learned from the PDA Tolerate trial and our own trial, that recruitment to these new trials can still be difficult. Either it is the clinicians, which was more common in America than it would be in Australia, or the parents, by explaining what this trial is actually looking for. So, should we treat the PDA with NSAIDS? I actually can only come up with one answer, and that is this one. Join a well-designed trial. And I'm still in equipoise of what to do with this particular population. I haven't swayed one way or the other. I'm still treating some babies with NSAIDS, and I'm also letting a lot of babies sort of go. And I still find it difficult to decide. One of the pure joys of the trial when we had it going on, you flipped a coin and that's the arm the patient came in. So the PDA was not a discussion point till 10 days later. It was fantastic. All right, I hope there's ample time for discussion and questions about this very difficult topic.
Thank you, Kurt. Okay, we have no questions on the chat group. Martin has just said happy to comment. So Martin, can you unmute yourself, please?
I have. Can you hear me?
Yes, thank you.
Julie, is it possible for me to just share my screen?
Definitely. I'll make you a co-host. Thank you.
While we're doing that, I'd just like to thank Kurt for a really clear talk, but with some really interesting new ideas. And I think Kurt's really leading the way here in a whole lot of different aspects of new ways to look at the PDA, and this is just one of them. He hasn't shown you all these other cool stuff about looking at left heart shapes and how they change, etc. But there's got some really interesting stuff coming. But really, just to address the issues around that have been talked about today. First comment I wanted to make was the Korean professor who did Professor Sung, who did the trial. I don't know if we've got any Korean listeners on today, but when they changed their management of the PDA to be from very aggressive to being very conservative, and at the end of that time, when they weren't treating any babies with non-steroidals, they had no babies discharged with an open PDA from their nursery, which I found very difficult to understand, because the correlation of reducing early treatment or any treatment has always been less closures and the risk of more babies going home with a PDA, which then results in a whole series of other issues for the baby and the family. And they've still got a left to right shunt even at discharge time. And that was the case in the Sembrova trial that Kurt showed. There was about 45, 50 babies who had an open PDA at the end of that management process, which is a significant imposition on healthcare. So I asked the Professor Sung what he thought they were doing that was resulting in that closure of the PDA without any non-steroidal care, so that all babies went home with a closed PDA. And his answer was pretty clear, and that was the way they managed their early fluids in the first 3 or 4 days of life. And they were doing a very conservative, restrictive regime of about 60 to 70 mils per kilo per day in their tiniest babies, and only going up when the sodium levels got to very high levels, over 150, 155. So very conservative management of fluid. So I'm just wondering, Kurt, do you think that's an issue? And it's clearly going to vary a lot between countries, between units, between clinicians.
Look, I think that there's more and more literature which points towards high volume loads, which we in Australia call normal, can be detrimental to PDA persistence. So when this chat session started, the Japanese group told indeed the same about how they approached volume in the very early days, and they were not as aggressive as you said, but they're way more lower fluid than we would use normally. And I've started an audit in our own clinic to see how much fluid do we actually give to the very small babies. Do we think it is only 80? But I actually already found it's usually 100 on the first day, 120 on the second day. So we already know from large trials and associations that more volume is usually lead to more PDA and more morbidity. So I agree. I think we're not doing everything we can in the first few days about fluid management.
Thanks, Kurt. The second thing I wanted just to address, which is again something Kurt touched on, which is the difficulties we have with this particular problem of the patent ductus arteriosus. So can you see my screen, Julie?
Yes, I can. Very good. Thank you.
So we have a multiple set of problems here which make designing PDA trials really difficult. And I think Kurt's very clearly outlined some of those difficulties and the way we've tried to solve them in our trials. But if you look at it, we've got drugs which have got poor efficacy, and even though we think they're good drugs, as Kurt's pointed out, a lot of the efficacy is actually spontaneous closure, and they're not actually as good as we think they are. We're talking about non-steroidals, paracetamol here. We've got the phenomenon of spontaneous closure, which can occur, of course, in a placebo arm or an active arm. And we've got the troubles with open label treatment. So if you look at what happens in a typical PDA trial, placebo arm, active arm, then my screen's not going to go through. Yeah, so in both arms, whether they've received an active treatment or they're the placebo arm, we've got spontaneous closure. So that'll mean there'll be ducts that will close even though they haven't received any active treatment. And equally, the phenomenon that Kurt referred to is that there will be ducts that close in the active arm, but not due to the medication, but due to spontaneous closure. We've then got, in the placebo arm, the problem with, as Kurt again pointed out, most of the trials have provided open label. So even in the placebo arm, we have some closures which occur because of open label treatment. And in the active arm, this is actually the group that we're trying to achieve, which is active treatment, active closure from active treatment. And then we've got this concept of failed treatment. So we'll have a group of babies who are given the medication, and for whatever reason, and there's lots of reasons, we need to look at pharmacokinetics, pharmacodynamics of the drugs we use. Kurt briefly mentioned that the best way to close the duct is actually a double dose of oral ibuprofen. And there's a whole lot of reasons why that might be, including pharmacodynamic reasons. So we need to understand our drugs better so that we don't get failed treatment, so that if we give a treatment, it closes the duct. Like a catheter treatment, if you catheter close the duct, or ligate the duct, it will be closed. But in the case of medication, that doesn't happen. And then finally, we've got the last issue, which is not quite coming up here, but that is the risk of actively doing harm in the active arm. So that then affects potentially our outcome at the end, whatever it might be, BPD or death, if we've actually caused harm by giving the treatment. So sorry, my screen's not flipping through the next thing, but the point I wanted to make then is at the end of this process, so you have multiple effects which are on the placebo arm, multiple effects on the active arm. But the problem is that when we look at the trial at the end, The placebo arm is really a proxy for the duct is closed, and therefore we're looking at the information and the clinical outcomes, assuming the duct is closed. And the active arm, the active arm is the closure of the duct. The placebo arm, the duct has still been open and causing harm. But in fact, all of these other things have occurred whilst we're waiting for that outcome to happen. So the end result is we have a very mixed group of babies in our PDA trials because of all these effects. So how do we sort these out one from the other so that we get a pure trial of the treatment and seeing if we give treatment, we get closure in 100% of cases, and then we don't get any adverse effects from treatment that's been given. That's the pure trial. How do we do that? And that's really what we've been trying to design a trial to do, is to try and account for some of these issues, but some of them we won't be able to account for. So I'd just be interested in your thoughts on that, Kurt, the problems of designing a trial in this setting of poor efficacy, spontaneous closures, and open label treatment rates.
Yeah. No, look, Martin, this is completely true. If you use a drug which is not really that good in any kind of trial, you're going to end up with mixed results. And you know, so this is indeed the issue. We need to probably look beyond NSAIDs or that particular treatment in this situation. And I guess when catheters really become safe, really safe, and you can do it early, you get you for the first opportunity. Or some other new drug might come up, which gives us the opportunity to look at that particular question. When we submitted the paper, you get a lot of rebuttals. You have to sort of deal with a lot of people to answer questions, and indeed this particular item came up for me more and more, like oh man, it's, if you want to answer the question NSAIDs are actually beneficial with a PDA, then that is the question we are doing with the pilot trial. That's the only question we're doing. If NSAIDs, specifically that drug, you can add paracetamol in there as well, I guess, if that's the question. If you want to do what do we need to do to the PDA to get better clinical outcomes, I think that's a very difficult question and a very different question, where indeed you might have different groups of babies to deal with.
We've got a couple of questions.
Yeah, so because this is Sunita asked a question about fluid restriction. They had a period where she describes we went to 60 to 70% fluid restriction, and I've read some of the literature, and some people sort of say that, and they go really low on their fluid. I think the Japanese also told that on their PDA management story, and it was quite impressive. And I wonder if that's the right thing to do. We have one trial from a Belgian group which looked at that kind of restrictions and found that it could actually affect organ perfusion. So I don't think that's the right, that's why we put it in sort of our guideline, and don't restrict too much. And the other thing I noticed in fluid restriction that, you know, that people are still feeling hesitant to use diuretics in a PDA because they say it works on the prostate gland pathway. But ductal remodeling is not just the prostate. Gland pathway. There's at least 8 or 9 different pathways described, which all have their effect on ductal remodeling. And the trials where we base this on, well, they're not even trials. Which were directed to the PDA. And it was the first line treatment for volume overload in most of our clinical situations. So I'm not hesitant to give diuretics at all. Loop diuretics is only going to be for a short period of time, a couple of days. And then we usually switch to spironolactone, which is a RACE inhibitor, which is probably good for diastolic dysfunction of the heart, and hydrochlorothiazide for usually a 2-week period and make a new evaluation of what's going on. This is all, of course, later in the phase of volume overload, not in the first 10 days. There's a question here about does diastolic dysfunction improve post-catheter or surgical closure if it affects long-term diastolic function? Do we need to treat earlier, maybe heading towards surgical closure? Well, the question is about if you can detect diastolic dysfunction. So you're already a couple of weeks old, and if you then do treatment either with diuretics or even PDA closure, does the heart recover? Our experience is called reverse remodeling. So the heart gets bigger and bigger, and then when you give the treatment or it closes spontaneously, the heart changes back into a smaller size. Our impression is that this reverse remodeling indeed takes place if treatment has been successful, either by actual closing the PDA, but most importantly, by changing changing the volume status and the shear pressures inside the heart. And the heart grows because of the amount of blood which flows into the heart. And Martin said, I'm doing quite a lot of studies looking at this particular phenomenon, and I thought I didn't have enough time to share this fancy stuff, so I left it out. But how the heart shapes itself, with or without a PDA and after preterm birth, is probably the most important factor for later adult heart failure. So this is an aspect and a concept which is growing in the literature and gets more attention, because our preterm infants which are now surviving are now all surviving and are now reaching the 40s and 50s. Well, before that, we don't have as many very young gestation age babies surviving. So our expectation is, in the literature points that out, that this remodeling of the heart as an important aspect of later heart failure. Much more detail is needed to see what will be the treatments. As you can imagine, treatments for remodeled hearts, you need a 20-year or probably a 60-year time frame to see if they're successful.
Probably one last question from Ivy. Oh no, hang on. Yes, they decided to ligate after 2 periods of oral ibuprofen.
So that is sort of what Sung also did, that they gave 2 courses of NSAIDS, and then if it didn't close, it was still a full, then it went straight to ligation. These approaches are most common in centers which have surgeon on site and can do this kind of approaches right then and there, sometimes even in the department. The only thing I can say that seems quite aggressive to me, and I think the study from Sung has shown that if you do it less aggressively and actually have some patients that a lot of them will still close and don't need surgical ligation. I still don't know how to select them best, but I feel more comfortable selecting babies for surgery than in the first 10 days of life, using usually other aspects of cardiac function and clinical steps.
Okay, maybe two last questions. Kurt, are you okay with that?
Yeah.
Okay,
So,
you
yeah,
have
asked about
4 minutes. There's one from Krishnamurti. Systemic steel, can we use systemic steel such as raised creatinine, Epsom diastolic?
oh, there. Oh, sorry. Yes, I was already at the bottom.
Yeah, you missed that one. And then also from
Yes, I would use systemic steel in the early phase, particularly in the first day after life. I use it less in the later day of life. So the hemodynamics of a PDA is, increasing left ventricular function, left ventricular stroke volume, and the increase in left ventricular stroke volume is more significant than sort of the reduced perfusion you can measure on each organ. What I think is a problem though from the PDA is not the reduced actual volume, so that's the steel you're looking at, changes it, but it's probably the reduced perfusion pressure. And there are 2 early studies which actually gave a bit of dopamine and showed that can be solved with some dopamine. Now, that's a quite intensive kind of treatment. But increasing systemic vascular resistance will certainly have an impact on the effect of PDA.
Okay, we have 2 last questions, Kurt. Because John Smythe raised his hand, we'll let him have a question. But first with Dr. Tetsuya from Tokyo, he's asked about how important PEEP is, P-E-E-P.
Yeah.
How high do you go?
Yeah. We go all the way up to 8 or 10
all the way.
in these particular situations, and it's usually a temporary measure. Look, there's only one small little trial which looked at that particular aspect, and they found that anything between 4 and 8 was sufficient. But I think the message I usually give here, if the baby has a PDA which is significant, don't try to file them off CPAP. Make sure that the CPAP is still important for this particular situation. Even though it's maybe in low oxygen need, but still has a PDA. The second thing is, instead of ligation, mechanical ventilation with PEEP is actually still a treatment for volume overload. And you need to balance that out between, mechanical ventilation for a period of time. versus ligation, which you think in your center will have the best clinical outcomes?
Okay, because John's one of us, right? We'll let him have a go. Last question. Do you want to unmute yourself, John?
Okay.
Yeah, thank you.
Hi, Kurt. Great talk. Fantastic. Just wanted to ask how we're talking about left to right shunts, lungs being affected, hemodynamic significance. How important do you think hemodynamic significance is? I mean, it seems a silly question, but
No, it's not a silly question. I think there's different phases. There was a which changes what you call hemodynamic significance, and that's what I've learned from Martin and Nick as well. That in the very first day, hemodynamic significance is something completely different. It's not just about the left to right shunt. It's still left to right shunt. It's combined with a low systemic vascular resistance and maybe a low cardiac output versus a PDA on day 10 is generally one of high cardiac output and low systemic vascular resistance. Usually a huge compensation. If you look at the interaction between the heart and the vessels, which is called ventricular arterial combination, so the VAC. They look at the combination between how they two interact. Then you can find differences in the first 3 days versus day 3 to day 7 to 10ish and beyond day 10. And I think in all these 3 phases, there's different parameters needed to look at hemodynamic significance of a PDA. I think the answer is just not as simple as just a PDA size or a left atrium size.
Okay, beautiful. We're out of time. I wanted to thank Kurt and Martin for the great presentation. If you have any questions, please feel free to email Kurt. His email is on the chat site. Once the recording is ready, I'll circulate it in the WhatsApp group. The link to join the WhatsApp group is on the chat site as well. So I put in details for our next meeting. It's about cord milking and cord clamping. It's a 3-way effort from the US, from Japan. Bye, everyone.
Thank you very much.
Bye.